Welcome to the NWAETC Project ECHO. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, to introduce our guest.
Well, welcome everybody to ECHO today, and thanks to Bob Harrington, first for doing this talk, second for being so patient. This is the talk that got rescheduled a couple of times, but we are doing it today. This is a hot topic, and I'll turn it over to Bob to talk about osteoporosis screening and HIV.
Yes, thank you, Brian. It's a pleasure to finally present this. I prepared it, I think, a year ago or something, and the problem with not getting to give it is that you have to update it every time. So it's been updated 3 times, and in fact, Brian tipped me off to a recent publication that's just come out in CID in January, and we incorporated recommendations from that paper into this talk. So what I thought I'd review today is some definitions that we all throw around with terms for describing osteoporosis, something on the epidemiology, which is a little controversial, and then talk briefly about the pathogenesis of bone disease and HIV from the standpoint of the virus, from the perspective of antiretroviral therapy, and then talk a little bit about traditional risk factors for osteoporosis and how they might be overrepresented in our HIV positive patients. And then we'll review screening recommendations, which are now maybe finally coming to the forefront. I was going to talk about treatment, but we're going to skip that and do that in a future talk. So first, some definitions. Just to remind us all what a T-score is. So this is a bone mineral measurement, bone mineral density measurement, and it is the number of standard deviations a person's BMD measurement is from that of a 30-year-old same-sex person. Okay? A Z-score is the same thing as a T-score, except the standard that you compare it to is that of the BMD of a healthy same-aged person. And it's important to note that we talk about Z-scores, but they're really not used to determine whether or not somebody has osteoporosis, and are also not used in decisions regarding treatment. And osteoporosis is defined as a T-score less than 2.5, so that means that person's bone mineral density is less than 2.5 standard deviations from that of a 30-year-old same-sex person. You have osteopenia if the T-score is between -1 and -2.5. And then osteomalacia is really a loss of mineral content of the bone, but you maintain the architecture of the bone. It really doesn't enter into discussions about treatment. So what about FRAX? So FRAX is developed by the WHO. It's the fracture risk assessment tool that incorporates clinical factors in addition to BMD. In fact, you don't even have to have a BMD to calculate a FRAX score, and it's done to predict your fracture risk if you don't have access to BMD measurements. A fragility fracture is a fracture resulting from a fall from a standing position. And bone mineral density is simply bone mass over bone volume or area. And we measure it using DEXA. And DEXA is absorptiometry, uses 2 low-energy X-ray beams to determine the absorption of both soft tissues and bone, and then it calculates the bone absorption by correcting for the soft tissue absorption, and that absorption correlates with bone mass. And then bone mass is divided by a calculated bone area to yield actually areal but not volume BMD. So they're using area as a surrogate for volume. So BMD is bone mass over bone divided by bone area or bone volume. So hopefully everybody's completely confused now, but you've been introduced to the terms that we'll be using. So what about epidemiology? So this study is a little older, 2006, but it's a meta-analysis of 11 cross-sectional studies that looked at 30 to 40-year-old HIV positive men and found that 67% met criteria for osteopenia and 15% had osteoporosis. And the odds ratio for comparing HIV positive people to HIV negative people was 6.4 for osteopenia and 3.7 for osteoporosis. This study is a little bit later and looked at fractures, so not BMD, but fractures in HIV positive patients, 8,500 HIV positive patients and 2.2 million HIV negative patients, and found that fracture risk, these are for, let me get the pointer here, this is women and men, and for women, any fracture, the gray bars are HIV positive women and the black bars are HIV negative women. and more fractures at the vertebral and wrist areas. In men, there were more fractures at vertebral, hip, and waist. And then when you track the fracture rate over time and over age, it's higher. The upper bar represents HIV-infected people, men or women. More recent studies published in 2014, the HIV Upbeat study. This was a prospective study of almost 500 patients, 210 of which were HIV positive. And HIV status was associated with lower BMD measurements at the femoral, neck, total hip, and lumbar spine areas. After adjustments for demographic, lifestyle, and BMI, HIV patients had higher bone markers or markers of bone turnover. And exposure to ART was not associated with bone mineral density. In the same year, 2014, the age HIV cohort looked at DEXA to compare BMD in 581 HIV positive patients and an equal number of HIV negative patients, all of whom were over 45 years. And osteoporosis was more common in HIV infected patients, but after adjustment for weight and smoking, the differences were no longer significant. So maybe just reflective of the fact that that HIV patients have more traditional risk factors for osteoporosis than HIV uninfected people do. And then this giant study out of the VA, the Veterans Aging Cohort Study, looked at 120,000 veterans, a third of whom were HIV positive, and found a fragility fracture rate that was slightly higher in HIV positive people. And after the adjusted hazard ratio for traditional risk factors, it was still significant, 1.24. But after adjusting for BMI, it was no longer significant. They did find that protease inhibitor use was a risk factor for fragility fractures. So it looks like patients with HIV do probably suffer more osteoporosis, and there's some debate whether or not they have more fractures or not. So how does this happen, or why does this happen with HIV? So what about the effects of the virus? Most of these studies are in vitro studies, and there's been the demonstration that VPR, one of the regulatory genes for HIV, and GP120, one of the envelope proteins, will increase osteoclast activity. The GAG proteins suppress osteoblast activity. And then activated T cells overexpress this rankle, which is a potent activator of osteoclasts and actually is a target for some treatments for osteoporosis. HIV is also associated with decreased production of osteoproterogen, which counteracts the action of rankle. And then there are other cytokines, TNF-alpha, IL-1, and IL-6, that are also overexpressed in HIV-positive patients, and those increase osteoclast activity. And then what about the effects of antiretroviral therapy? So probably the best study that looked at this was a randomized prospective study. You might remember the SMART study, where patients were randomized to continuing on antiretroviral therapy or interrupting it and then restarting it when their CD4 counts drop below a certain level. So in this graph in the upper left panel, the blue line just represents people that are on continual viral suppression, so they stayed on antiretroviral therapy, and then the red line is just showing that people interrupted therapy. So this is ART use, and the red line obviously shows that there's less ART use in the people that were randomized to that arm. And then they looked at BMD measurements at the hip and at the spine, and then at the spine again by a CT scan. And the group that interrupted antiretroviral therapy had better BMD scores, bone mineral density, than the groups that continued on antiretroviral therapy. So most studies show that there's a 2 to 6% loss of bone in the first 1 to 2 years after people start antiretroviral therapy, and this is thought to be due to a rise in CD4 count and more activated T cells being around and an increased expression of rankle, which stimulates osteoclast activity. Individual agents, protease inhibitors, are associated with lower BMD and an increased fracture risk, and this may be because they inhibit osteoblast or osteoclast differentiation and interfere with vitamin D synthesis. Efavirenz is also associated with lower BMD in some studies, and it's thought to be due to increased vitamin D metabolism. And then we all know about tenofovir. Most studies show that people taking tenofovir have a decrease in bone mineral density of up to 2%, and it's also associated with an increased fracture risk that's mediated through loss of phosphate in the urine. And then this is the Veterans Aging Cohort Study again, a little bit later publication, this in 2013, looked at 40,000 people, 500, all of whom were HIV positive, 588 fractures. The graph on the right shows that the older you are, the more likely you are to develop a fracture. And when they looked at individual fracture risk factors, so white race, BMI, alcohol use, PPI use, and steroid use, they were all overrepresented. Their hazard ratio was greater than 1 in HIV-infected people. And they developed this VAX index score that included age, HIV RNA levels, hemoglobin, FIB4 score, CD4 count. And the higher your VAX index score was, the more likely it was that you would develop a fracture. So how do we take all that HIV patients probably do have a higher risk of osteopenia and osteoporosis and probably have more fractures than HIV uninfected people, and how do we screen for these diseases? So these are screening recommendations from a few societies. The USPSTF recommends that women over 65 or women less than 65, if they have a risk for a fracture that is greater than that of a 65-year-old woman, should be screened for osteoporosis. There are no screening recommendations for men at any age. The National Osteoporosis Foundation suggests that anyone with a fragility fracture should be screened. Women over 65 and men over 70 should be screened. And then postmenopausal women and men over 50 with other risk factors for osteoporosis should also undergo regular screening for osteoporosis. The HIV guidelines are in line with the NOF guidelines, and since HIV can be considered a risk factor for osteoporosis, basically say that anyone who's over 50 ought to be screened regularly for osteoporosis. But then this new group just published this paper that came out just last month. Bill Powderly was the senior author on the study, and it was from several countries around the world that got together, osteoporosis experts and HIV experts, and came up with the following recommendations. So if you start with HIV positive adults, if you have a history of a fragility fracture, if you've been on steroids greater than 5 milligrams for longer than 3 months, if you're at high risk for falling, if you're a postmenopausal woman, or if you're a man over 50, then you should have bone mineral density screened by DEXA or a FRAX score calculated if DEXAs are not available. If you don't have any of those risk factors and you're between the ages of 40 and 50, then calculate a FRAX. And if you're less than 40 and you don't have any of those risk factors, then there's no need for screening. So if you calculate your FRAX and it's less than 10%, then calcium, vitamin D, and lifestyle advice. If it's between 10 and 20 or over 20, then it's best to measure your bone mineral density by DEXA. And if your score meets criteria for osteoporosis, so less than 2.5 or less than 2.5 standard deviations from the bone mineral density of a 30-year-old, then you should be treated for osteoporosis. Or if your FRAX score is greater than 20, meaning you have a greater than 20% chance of having a major osteoporotic fracture in the next 10 years, or a hip fracture greater than 3% in the next 10 years, then you should also consider treatment for osteoporosis after you've excluded secondary causes of osteoporosis, and I'll go through those in just for a second. So treatment, we're going to cover at a later date, but it's basically calcium, vitamin D, and you can consider bisphosphonate therapy. So after if you decide to screen your patient, then what about follow-up testing and screening? If you should recalculate the FRAX every 2 to 3 years. If your DEXA score was between -1 and -2, then repeat it in 5 years. If it was between -2 and 2.5, then rescreen in 1 to 2 years. And if you're been on bisphosphonates, then the DEXA should be repeated in 2 years, and then reassess the need for bisphosphonates in 2 to 5 years. I won't go through this in any detail, but there are endocrinologic, renal, gastrointestinal, and hematologic reasons why people can be at risk for osteoporosis, and these are the screening tests or evaluation you could do to look for those problems. And then the FRAX tool, I don't know if anybody's using those regularly. You can get to it easily by just Googling FRAX. It's tuned to the country where you live, so make sure that you pick North America or the United States, and then you basically fill out these risk factors, and it generates a score for you. So I did that I just put in the data for a 65-year-old, 60 kilogram, 5-foot 10-inch man who's HIV positive. He smokes. One of his parents had a hip fracture, and he did have a DEXA scan done, and his score was minus 1.8. So then it automatically will calculate for you the risk for a major osteoporotic fracture and the risk for a hip fracture in the next 10 years. And this guy keyed out with 11% and then a 2.5% for a risk fracture. So he didn't quite meet criteria for consideration of treatment with a bisphosphonate for osteoporosis. One thing with the FRAX score to note is that you can check this little box here, or this little button, for secondary osteoporosis. And if you consider HIV a condition that is categorized as can cause secondary osteoporosis, then click that button, yes. That will change the formula a little bit and the output of the calculation. And the most recent paper that I quoted suggests doing that when you calculate your FRAX score for your patients. So we were going to talk about treatment, but we're out of time. We'll do that in the next lecture, but I'm happy to entertain any questions at this time.